Sorry? So it looks like we don't have as many people interested in prostate as in breast and thyroid. So prostate cancer is the most commonly diagnosed malignancy in men, excluding skin cancer. In the United States, there's almost 250,000 new cases every year. And the screening standard, at least in the United States, has been the digital rectal exam and PSA. And if there's an abnormality in these, they usually do a transrectal ultrasound, 12-core sextant biopsy without definite imaging guidance. And there's two major drawbacks to this. There's a substantial number of unnecessary biopsies with no or indolent cancer, and the false positive results are very common, greater than 50%, and 20% of prostate cancers will have a normal PSA. In the United States Preventive Task Force advised actually that PSA screening not be done because of the complications of a low-risk biopsy, the complications and the low-risk and the low positive biopsy rate of prostate cancers. So multiparametric MRI is increasingly used for detection and staging of cancer, and we use it quite often. And while multiparametric MRI sensitivity is high, its specificity remains low. Conventional transrectal ultrasound has limited sensitivity and specificity. In contrast, ultrasound is being used, is currently under investigation. In the past we've used it and it hasn't worked very well, but with new software to analyze the time intensity curves, there's some literature that suggests we may do a better job. In elastography, both strain and shear wave have recently shown promise in detecting prostate cancer. So both strain and shear wave have been used to detect and characterize prostate lesions. The World Federation of Ultrasound and Medicine has provided guidelines for the use of both strain and shear wave for prostate elastography, and I'm just going to go over the key recommendations for that. So for strain, recommendation was technical recommendations for optimal acquisition should include minimal preload, not to push on the prostate. The focus zone should be placed in the far field of the region of interest. The field of view size should include the prostate capsule and some periprostatic tissue, but exclude the bladder. Recommendation 2 was it is better if an area of concern can be localized in the center of the field, and I think Dr. Christoph mentioned that in his first talk. Because you have a curved surface, you want to have the lesion in the center, so you're applying pressure appropriately at the lesion and not on the ends where you'll have different pressures. Recommendation 3, although several methods for interpreting strain of the prostate have been proposed, a uniformly accepted scoring system has not been established, and any of the proposed scoring systems can be used. Recommendation 4, the PIRAS lexicon terminology and lesion location should be used in reporting results. Recommendation 7, strain elastography should not be interpreted without considering the conventional B-mode findings. Recommendation 8, the addition of strain of the prostate can increase the prostate cancer detection rate, and we'll go over how to do that shortly. The addition of strain of the prostate increases the positive biopsy rate compared to that of truss. So using elastography to guide us to do our biopsies in the stiffest area does improve our rate of detection and increase the positive biopsy rate of prostate. Recommendation 10, strain elastography of the prostate is of limited value in the detection of small cancers and may miss carcinomas with a lower Gleason score. So in general, with strain, we cannot see cancers that are a centimeter or less. And Gleason scores 6 and less, it's very difficult for us to pick up. So the strain elastography is very good at picking up more aggressive cancers, Gleason 7, 8, or 9, and lesions that are above a centimeter. Recommendation 11, strain elastography targeted biopsy should always be performed with systemic biopsies. So in other words, you normally do your 12 sextant biopsies. You should still continue to do those and then do the guided ones to the areas of concern on the strain imaging. So you would do your normal 12 plus any addition of a lesion that you find. Recommendation 12, strain elastography cannot be used as a decision tool to rule out cancer without a biopsy. So in other words, a negative strain elastography of the prostate cannot be used to say the patient does not need a biopsy. They should still get their 12 sextant biopsies. Recommendation 19, the addition of strain imaging of the prostate can improve staging over that of truss alone. Recommendation 20, although strain elastography may detect capsular or extracapsular extension, strain of the prostate cannot exclude capsular extension or extracapsular extension. So in other words, we can't really grade the tumor extent of tumor invasion with elastography. The addition of shear wave of the prostate can improve lesion localization for image-guided prostate biopsy. And I think that's what we use. This is mostly to localize the lesion, and we tend to try to combine it with MR information and do an ultrasound-guided MR fused biopsy where we biopsy both the MR abnormalities and the ultrasound elastography abnormalities in the same setting. There are a couple methods of evaluating these. Dr. Zhu from China has a 5-scale score. Score of 1 is a normal appearance. A homogeneous strain, the entire gland is evenly shaded in green, so green is soft. Score 2, probably benign. Symmetric heterogeneous strain, the gland is a symmetrical mosaic pattern of green and blue. 3, indeterminate. Focal asymmetric lesions without strain, not related to hypoechogenistic lesions. The focal asymmetry lesion is blue. A score of 4, probable carcinoma, strain at the periphery of a hypoechoic lesion with sparing of the center of the lesion. The peripheral part of the lesion is green and the central part is blue. And 5, definitely carcinoma, no strain in the entire hypoechoic lesion or the surrounding area. The entire lesion is blue and stiff. And here is examples, and this is from the Wolfram Guideline paper, that the gland here is mostly green, and then we get a little bit of blue, and now we start seeing a very stiff area that has a hypoechoic area, a larger area here, and again, more blue with a little bit of green, and then a very stiff lesion. And you can see that the majority of these things that we're seeing are in the peripheral zone. And in our experience, we do really well in the peripheral zone, but in the transitional zone, we have some problems. There's another 5-point Innsbruck scale, which is a little bit different. A score of 1, no blue areas or star-like blue in the peripheral gland. A score of 2, mosaic or small symmetric blue areas bilaterally in the outer gland, and the blue area is less than 5 millimeters in diameter. 3, a small symmetric blue area in the outer gland, greater than 5 millimeters. 4, asymmetric blue area in the outer gland, diameter of the blue greater than 5 millimeters. And asymmetric blue area in the outer gland, which is greater than 50%. And again, some examples, and again, you can see we go blue, and here you can start seeing we've got these dark blue stiff areas that are the cancer. And the more blue the lesion is, the higher the probability of having a prostate cancer. And again, you can see that we're looking mostly at the peripheral zone. If we go to shear wave, recommendation 27, and approximately stabilization time of 4 to 6 seconds is needed in shear wave elastography to obtain an optimal image. And this is really dealing with the supersonic system, which I think at the time of these guidelines was the only one that was really doing prostate shear wave. Recommendation 28, if the area of concern is at the edge of the image, rotating the probe to have the field of view in more central on the lesion is helpful. So very similar to strain, you want to adjust the probe so the lesion is centrally in the transducer. Recommendation 31, the mean stiffness value in the ROI should be reported. The ROI must be adequately placed. So in other words, we're going to look at the mean of the entire lesion when we give our cutoff values. Shear wave imaging should not be interpreted without considering the conventional B-mode imaging. Recommendation 37, a stiffness value of greater than 35 kPa is suggestive of a malignancy. Recommendation 38, limited studies suggest that the stiffness value of a lesion correlates with the Gleason score. And I'll show you a study that we did in conjunction with Michel Corrias from Paris that it looks like we can use the stiffness value to correlate with the Gleason score. Recommendation 40, the addition of shear wave elastography to the prostate can increase the detection rate of prostate cancer. 41, the addition of shear wave of prostate increases the positive biopsy rate compared to that of truss. So we do much better in finding these lesions with the elastography than standard ultrasound. Shear wave elastography targeted biopsy should always be performed with the standard systemic biopsy. So just as in strain, we recommend you do your normal 12 biopsies and then biopsy in addition anything that's abnormal on the elastography. Shear wave cannot be used as a detection tool to rule out cancer without a biopsy. So again, we can't really use this technology to prevent doing biopsies. The addition of shear wave elastography to the prostate can improve staging over truss. And although shear wave elastography can identify capsular or extracapsular extension, shear wave elastography of the prostate cannot exclude capsular or extracapsular extension. So we presented our single-site study of almost 300 biopsies where we used a supersonic 2D system, and these were our results. And we had cases that were benign, atypical cancer, acute, and chronic inflammation. And what was really interesting here is you can see that the cancers actually separated themselves very well from benign, atypical, as well as acute and chronic inflammation. And when we were using contrast ultrasound many years ago, our big problem was that both chronic and acute inflammation had very similar CUS patterns to cancer. It was very difficult to distinguish those, but that does not seem to be the case with shear wave elastography. There's been many studies looking at systemic biopsy to assess the dynamic performance per core or per patient. And here you can see the sensitivities, specificities, positive and negative predictive values. The first half of this is strain, the bottom half is shear wave. And I think you can see that the shear wave studies are all performing much better than the strain images. So I'd like to just go over the study that we did with Jean-Michel Corrias from Paris. It was a prospective study for the diagnostic performance of real-time shear wave elastography and detection and characterizing prostate lesions in patients with high and or rising PSA or abnormal DSA, DRE, and this was published in 2015 in Radiology. And we performed the shear wave imaging using the supersonic imaging system, using their 12-3 endocavity rectal probe, and these were all done before the biopsy. The exam was performed by one of two radiologists with greater than 3 years experience. The patients were in the left lateral decubitus position. We made sure we did not apply much pressure with the probe. We used the penetration setting. The scale was set to a maximum of 70 to 90 kPa. The probe was held still for about 3 to 4 seconds for each measurement, and the entire gland was evaluated, and the maximum kPa stiffness values were documented. Transrectal ultrasound-guided biopsies were performed with an 18-gauge true-cut needle, a minimum of 12 biopsies with paramedial and lateral cords for each sexton. Additional cords were taken for suspicious areas with the locations documented. The Gleason score and prostate intraepithelial neoplasms recorded for each specimen, the length of each biopsy, and the length of the adenocarcinoma tissue was marked. So here's an example from our site where you can see a very stiff area where we did our measurements, which was 108 kilopascals. So one of the problems that we've had with the shear wave elastography is the central gland, the transitional zone where BPH occurs, was almost always very stiff, and it was very difficult for us to interpret that because almost everyone has a very stiff gland. So really, we're only looking at the peripheral zone where about 70 to 75% of the cancers occur. And this is why we like to do this in conjunction with MR, because although we think we do really well in the peripheral zone, MR does really well in the central gland, so we can pick those lesions up. I will say that Supersonics has recently, instead of having this field of view, an entire field of view that will encompass the entire gland, and we can see these areas. And Dr. Corius, in his initial studies with that newer probe, shows that if you have one area that's much stiffer in the transitional zone, it's suggestive of a malignancy. An official study has not been done with that yet. So we had 184 patients, almost 12,000 biopsies. The positive biopsy rate of targeted biopsies was 40%, or 55 of 137, where if we just looked at our sextant biopsies, the positive rate was 15%. So almost 3 times more detection of cancers with the guided biopsies as opposed to the unguided biopsies. And again, they found the same cutoff value as our first study with 35 kilopascals, which corresponds to 3.42 meters per second to diagnose those. This is the ROC curve, sensitivity of about 80%, specificity of 92%, positive predictive value of 62%, and a very high negative predictive value of 96%. These are the box plots, and again, a relatively good separation between benign and malignant lesions. We also did the ratio of the lesion to the background tissue and saw similar results. And again, if we look at the sensitivity, specificity, and positive and negative predictive values, you can see that with the elastography and B mode imaging, we had a much higher sensitivity. If we used the strain ratio, we even did a little bit better. However, when we used the strain ratio, our specificity decreased. So the area under the curve, where we had the best results, was just using elastography alone with a cutoff value of 35 kPa. Another interesting thing we found, if we plotted benign versus Gleason 6, Gleason 7, Gleason 8, and Gleason 9, you can see that there's a trend for higher stiffness values as the Gleason score increases, particularly at Gleason 9. And we did have, comparing Gleason 6 and 7 to 8 and 9 was statistically significant, as well as 6, 7, 8, and 9. So again, in the future, as we look at this technique, we may be able to decide which patients are most appropriate for aggressive treatment and others that may be with just watching. Some additional examples, and again, we're really looking only at the peripheral zone, and here you can see a benign case, KP values of 13 and 18, and here another positive case where the majority of this outer gland here is soft, but we've got a nodule that has a KPa of 54, and this is showing you doing the strain ratio where we've measured the lesion is 54 and the background gland is 18, gives us a strain ratio of 3. Another thing that we found was we do much better than evaluating hypoechoic lesions. So this is an example where we have a hypoechoic lesion, which we would consider biopsying based on the grayscale, but it turns out on elastography this was a soft lesion and was benign, but there was a lesion here that we don't see at all on B mode that actually turned out to be a Gleason 7 score. This was a gentleman that, it was an elderly black man who's had multiple prostate biopsies because his PSA keeps going up, and his elastography was completely benign. So he's had so many biopsies, we just look at him now, and if he continues to have very soft gland, we don't think, even though his PSA is going up, it's probably because of inflammation and not because of cancer, and try to prevent him. The guidelines do not recommend us not doing a biopsy based on elastography, but I think in certain situations this may be very helpful. If we can improve our results a little bit better, we may not have to do the sextant biopsy, but right now we really need to continue to do that. So to conclude, strain and shear wave elastography have been shown to improve detection and characterization of prostate lesions. However, a sex-ed biopsy is still required. Prostate cancer stiffness increases with Gleason score and therefore are strongly linked with prostate cancer aggressiveness, especially for elevated Gleason scores of greater than 7. So in the US now, if they have a Gleason score of 6, their patients are just watched and the PSA is monitored and don't undergo any treatment, but PSAs of 7 or greater are more aggressively treated. If systemic biopsies were performed only in the stiff areas detected on shear wave elastography, the biopsy rate would have increased from 15% to 48%, so significant increase in the detection of prostate cancers. And again, we have not done a study with including MR yet, but I think a lot of the cancers that we're missing with the elastography are those in the central gland that we're not doing very well, which MR picks up very well. So the combination of using MR and ultrasound and have MR ultrasound guided fusion is, I think, going to be very helpful. And again, because it looks like the Gleason score is correlated with the stiffness value, again, we can guide our biopsies to the stiffest area of a lesion to hopefully get better correlation with the aggressiveness of the tumor and our core biopsy. And shear wave elastography may be helpful in decreasing the number of biopsies in the future thanks to its high negative predictive value, which is greater than 99%. Again, we don't recommend that, but we think that with additional studies, that could be very useful. Thank you.
Thank you so much for the interesting presentation of Professor Ba. The next topic, we would like to invite Professor Christopher Distris present the topic, the future of elastography and ultrasound and new application.